Hey everyone, it is Wednesday. You know what that means? It's Hump Day, and that means it's time for Dennis in the Know Hump Day Happy Hour. This is your backstage pass for current trends, politics, and education in the dental world. We are live, and we are over a little wine, a little Pinot Gris tonight. I'm enjoying after a couple of pretty crappy days of work, but we'll get more into that. But I shouldn't complain too much, but I will anyway. Regardless, I'm here with a couple of my best friends in the industry. We do this every single Wednesday, and I do it with two of the best people in dentistry, Dr. Chad Duplantis and Dr. Jennifer Bell. Together, we are the dentists in the know, and our job is to bring all of you in the know. We are all practicing dentists, we are all business owners, and we're all educators. So, guys, we have a great show tonight. PreXion is sponsoring our show tonight. We have a great speaker, Dr. Ankur Gupta from the Catapult Group is with us tonight, and we're going to be talking CBCT. So let's start with how your week was. How's it going, my friends?
It's fine.
Yeah, that's not encouraging. Chad?
How's your week, Chad?
It's fine.
Good.
Guys, I told a patient today, I said,
we're going to lose our only viewer.
I know. I told a patient today, I said, I'm just really having a hard time getting my engine started after Easter. I don't know. It wasn't a banger holiday. It wasn't, a cruise. It wasn't, I'm having a really hard time this week, like kicking it into gear. What's going on?
Yeah, just everything, man. Just parents, we've been through this over the years already, and just another episode
Tax day.
Dealing with aging parents, tax day, business closings, buildings, people who want to see 4 different dentists and just have each one do what they want them to do, and just weirdness everywhere, just stuff just going on in such a disorganized fashion, and just, okay, what do you got next, life? What are you gonna throw at me this week?
Spinning.
Just that kind of thing. Yeah.
Spinning.
Yeah.
Did you have a good trip to Buffalo?
I had a great trip to Buffalo. So for those of you who don't know, my son Luke, who is an artist by trade, please remember to silence your cell phones. That's Luke as we speak.
Are you kidding me right now?
Yeah.
In the hell
You
is
couldn't
that?
have timed that
I'm
better.
like looking at my phone, like, is this me?
How crazy is that? Yeah.
Luke, we're busy.
We're busy.
Clearly, he's not one of the few watchers.
Yeah. Well, now he is actually in the industry, so
he should be watching.
He will become a viewer and a member of Dennis in the Know. But Luke has been an artist by trade. He was in the movie industry for a while, and things kind of really slowed down in Chicago. And Luke is now doing digital design with our friends at Evolution Dental Lab and Evolve. And like last week, I think it was a short week, and he ended up doing like 90 crowns. And I mean, he's pumping it out down there on the digital design. He's going to start working on some full art stuff. And I was up there, we were looking at cases and we were nerding out. And, it's not how I ever thought Luke was going to be in the dental industry, because I always imagined him coming in and taking over the practice. And neither one of my boys really wanted to do that. And but here he is in the dental industry, totally nerding out on the lab stuff, loving it, in a room with 15 or 20 other people his age, jamming music, doing digital design, and just nerding out on all the cool new technology. So that's what I was doing in Buffalo, was visiting Evolution Dental Lab and my son.
I wish we could get the message out more that the dental lab industry is such a great place for creatives, and it's such a great space for artists who, maybe haven't quite found that niche of application for their creativity. And there's such great learning programs and such a demand for those individuals to come into this space. So I am so excited to see him coming into that dental laboratory space, because he is the exact description of someone who is going to excel. And I hope more people who have that creative spirit, like to do different types of three-dimensional art or even drawing and different mediums, would at least consider a dental laboratory technician as a potential job, because I think they could find both sides of that. I need to make money and pay my bills, but also I can apply my creative arts and my desire to want to create. And I don't know, maybe Luke has kind of divulged this a little bit, but I would think it's not just creative in the dental creation side, but just the collaborative, like you've got all these creatives sort of feeding off of each other and geeking out together all day. Like, how fun is that?
Yeah, I wish you could see the environment, because it's not like the dental lab of old. It's not like the old,
Exactly.
where you walk in and it's just this cloud of acrylic smoke and a bunch of lab benches. Don't get me wrong, there's still a finishing room where the master technicians are finishing some of the pieces and everything, but so much of it is creative space and collaboration, and it looks more like Google headquarters than it does
Right.
a dental laboratory. And these big screens, multiple screens with these gorgeous designs, and you're like, I can't believe that this is the laboratory space now. And it was pretty cool to watch and to see how he fit right in there. Like
I love
literally, when I pulled up there, everyone comes running out like, "Oh my God, we love working with him. It's great." And he took right to it, loves the atmosphere. And it's really, it's the first thing that I've seen him this excited about. And he truly is. He went to IDS with me and he was geeking out there, but I don't think he understood the full scope of what it all was. But bringing that technology and computer skills and creativity and artistry together, I mean, really the sky is the limit for somebody who wants to immerse themselves in it. And he's seen that. So it's exciting.
Were there a lot of buckets? Like, did you notice a lot of buckets in the lab?
They do. They have a lot of buckets, and you never know what's going to go into the buckets.
You don't.
No,
You don't.
yeah. So
And you
sometimes
never know what's going to come out of the buckets either.
No, you don't.
Yeah, they actually had one bucket that was full of dentures that yeah, Luke tried a bunch of them in. Yeah, and I was like, yeah, maybe don't do that.
Yeah, maybe no.
How about no? Chad, you've been quiet up there. How you doing?
I don't know that I was invited to the conversation, so I just sit back and listen and just kind of nod.
He's the producer.
Yeah, I'm the producer. Yeah. I'm over here on my little telly, just working
sounds.
But you know what I want you to talk about for a moment? I want you to talk about your son Austin's final performance, because you went to Nashville to see Austin do his, I think it was his final improv performance. And for those that don't know, Chad's son has been at Belmont University, and he is quite the funny soul. So tell us about that.
Well, that was really fun. It's kind of funny. You're sitting here talking about what your son's doing, and your son and my son are a lot alike. His final performance was fantastic. I'm not going to lie. I mean, not just because it's my kid, but I do think there's a future there. Let's just hope it's with Saturday Night Live, which is where his dream is. So, Lauren Michaels, if you're watching, hire Austin Duplantis out of Nashville, Tennessee. He'll be submitting an application on June 1st. But
I'm sure he tunes in regularly.
Yeah, regularly.
Yeah.
But actually, we have graduation next week. So it's been kind of funny because, Dad's not really in tune with what exactly a film degree entails. And, I know there's a lot of fun and there's a lot of funny and there's a lot of this and there's a lot of that, but there's not a lot of like, how's the money going to come in after you graduate? Yet today, he had an interview at the production company that produced the movie Long Legs. Have you all seen that? It's a new horror movie.
Clearly, that was about me.
Newish horror movie with Nicolas Cage. And so,
not called Tiny Legs. It's called Long Legs.
It's called Long Legs. It's actually a pretty freaky movie if you're into horror movies. But
that's why I haven't seen it.
Anyhow, he had an interview today. He said that went well, and it looks like he might have a job that actually pays besides Trader Joe's and Starbucks. So we got a couple things on the horizon.
These are good things.
These are all good things. Yes,
good things.
yes, but I don't know that it pays enough to where Dad is not going to have to subsidize for a while. If you catch my drift. So
he does like a seafood tower.
It is. Yes, it does.
He has expensive taste.
He has fancier taste than Luke does, but
for sure.
But the other side of that is 29. So I'm ready.
True. True. So, anywho,
are we ready for some news, boys?
Let's do some news so we can get on.
We got a great guest waiting. Let's do some news.
All right. Well, I couldn't pass this story up, so we're going to start with this first. Because I've read a lot about the correlation of good gut biome and just general good health. So when an article came out that correlated how often you poop with how healthy your mouth was, well, I had to dig in a little bit deeper. So I think it's important to understand those with chronic constipation and those with chronic diarrhea might not have the best oral health. Those of you watching tonight or the next couple of days that poop somewhere between 7 to 8 times a week, well, you might just be at operating efficiency for good gut biome as well as good oral health. This was backed by 7,512 adults that they surveyed and studied with their bowel habits and their oral health screens, looking for different disease processes that might be correlated with poor oral health. Those who had chronic constipation, 45% greater odds of poor teeth. Those of you with chronic diarrhea, 24% increase in poor teeth. So I think the correlation here, the takeaway message is obviously there might be some connection. It's the thing that dentists have been screaming for years. The oral cavity is not just a separate entity that you take on vacation. It is connected to systemic health. When the gut biome is happy, the oral cavity is happy, and vice versa. When the oral cavity is happy, gut biome is happy. In fact, as best I understand, that is one continuous track from start to finish. So it might behoove us all to focus a little bit more on making sure that both ends of the track are operating at full proficiency. We're seeing a lot more uptick in dental loss ratio. That's been a big hot topic since 2023 when Massachusetts question 2 came up. But many states are also taking that mantra and bringing it up for additional voting. In fact, North Dakota is now the most recent state to pass a dental loss ratio of 75%. Now, what does that mean for our viewers? Just to refresh you, dental loss ratio means that when an insurance company is collecting premiums, 75% of that value needs to be directly reapplied back to care. Anything beyond that would be administrative costs, et cetera. That falls in the North Dakota case in the 25% bucket. If they don't hit that measure, they owe money back to their subscribers. Of course, that doesn't mean increased reimbursement back to providers, but at least there's renewed focus on making sure that when we're collecting premiums, that is going directly back to the patient in some form of education and services. So right now we have 23 different states that either have introduced legislation, passed legislation, or have upcoming legislation for review. That's certainly a pretty big uptick from the 2 states we saw back in 2023. So this has become a pretty hot topic for a lot of legislatures and a lot of state legislatures to look at making sure that dental premiums are at the benefit of the patient. Another interesting study that came out of the Economic Outlook and Emerging Issues. This is an ADA quarterly poll they've been doing since the pandemic and with the HPI, looking at different statistics amongst our profession to see how we're performing, to look at what the impact of the pandemic has had. But what has evolved is really just looking at the dental industry as a whole. One interesting survey that came out recently from this particular collection of data was the 10 different measures that they surveyed, or 11. How many of those different measures are offices still implementing today? So, for instance, if your team is still wearing N95 masks, face shields, disinfecting multiple surfaces throughout the office, not just your normal routine cleaning and within the infected areas of your operatories, pre-screening for COVID symptoms prior to showing up at the office, air purifiers, different types of other physical protection mechanisms, checking staff members' temperatures. The question was, how much of that is still in place today? And actually, nearly 94% of dentists cited that they're still doing some or all of these different measures that started back in 2020. I thought that was super interesting, especially because I'm not sure if I'm doing any of them. I mean, we just went back to business as usual. Judge me if you will. That's fine. But I always thought dentistry was actually at the forefront of managing infectious disease long before COVID came. We were all wearing masks. We were all doing protection. We were all disinfecting those operatories routinely, managing aerosols with our high volume suctions, et cetera. Like, I really thought we were doing a lot of things really great already. Some of the pre-screening stuff wasn't on board yet, but we implemented that quite quickly. But it looks like a lot of these parameters are here to stay, or at least for the next little bit. So we'll continue to monitor that and see how that evolves. The last story for tonight is a bit of an economic discussion. We're going to get you kind of like the first story from the beginning to the end. Now, an interesting study, correlation of data came out not that long ago of the top dental schools in the US. Now, I think there was a lot of debate about that, but personally, as a graduate of UNC Chapel Hill, I was happy to see that it was number one. I think it stirred a bit of debate amongst many of us within the profession wanting to know the criteria, and I get it. But again, if you're the graduate of the institution that earned that banner, you're just not going to fight it too hard. But the interesting thing about this next story is, okay, let's take the top 10 schools as identified by this particular study coming out of bestdentalschools.org. Not really sure that's a real thing, but we're going to go with that for a minute. What's the cost to go to one of the best dental schools in the US, according to this particular ranking system? Well, if University of Chapel Hill is number one, and I would debate that it is, total in-state tuition for your 4 years of dental school, not including cost of living, is $153,000. A non-resident tuition is $291,000. This ebbed and flowed somewhere between $150,000 to $200,000 for in-state tuition, versus somewhere between at the low end, 157 for out of state at Texas A&M. Good job, Chad, and your Texas fellows, all the way up to $454,000 as a non-resident tuition from the University of Missouri, Kansas City School of Dentistry. So all over the board. But general consensus is it is roughly right now $150,000 at minimum to go to dental school, and could be as high with non-resident tuition at the top 10 of right at $500,000. Now, why is this important? How much do we make once we get out? Well, the interesting story on the flip side of this is, where are the top 10 cities to earn an income as a dentist once you graduate? The U.S. average salary for a dentist right now is around $196,000 a year. But if you happen to go to the coast, Oregon, non-metropolitan area of the U.S., you can earn yourself $279,000 on average, all the way down to our great city of Columbia, South Carolina, not that far from our dear Jeff Horowitz, at $250,330. Now, what I did learn from this particular story is not one of the 3 hosts that host this show every week lives in one of the cities that earns the highest income potential for a dentist. In fact, I don't know many. I might know 2 dentists from any of these areas. That might be food for thought. Now, could you possibly process the idea that the most earned income for dentists might come from areas with either the least saturation of those professions in that area or a lower density of population? You could also correlate with that. Is that where dentists want to live, or are they going home? Lots to digest in this particular story. Just depressing enough to know that none of us happen to live in any of the cities where dentists are earning a real income. And with that, that's the news.
So, what was the average salary of a dentist in Denmark, South Carolina?
Columbia? There is no dentist in Denmark, South Carolina.
There is. This is a booming metropolitan area. Denmark.
Well, they didn't
South
make the
Carolina.
list, guys. Sorry.
I don't know how.
Sorry.
I'm not there, and I think, thank goodness. But
Great news episode. We talked about poop. We talked about poop in the form of the cost of dental school tuition. I'm blown away at how much UMKC is. I think that's got to be a typo. I would see.
Well, the in-state tuition is, hold on. The in-state tuition for that school is $207,000. Non-resident is $454,000.
Okay. Yeah, very, very interesting. Anyhow, we have a great guest waiting. Can I introduce him while we bring him up?
Please.
Let's do it. I'll bring him up because I know you can't do that.
I can't walk and chew gum, but
we know.
I am going to tell you that you're in for a real treat tonight because you are looking at one of the most energetic, as well.
Is it me or is it him?
Oh no, Chad's internet is crapping out.
Nicest people in dentistry. He's one of those people that when you meet, you just don't forget. Got a great heart. He's a great clinician. He's a great speaker, and he's got more energy than the Energizer Bunny. But how he graduated dental school at Michigan in 2004, completed a 1-year GPR in Cleveland, Ohio. He and his wife, Dr. Nisha Gupta. In addition to founding North Ridgeville Family Dentistry, Dr. Gupta is a member of the ADA, the Greater Cleveland Dental Society, the Ohio Dental Association, the ADA Success Speaker Corps, and an active board member and speaker for Catapult Education Speakers Bureau. And it's an honor to have him here tonight speaking on cone beam and really just kind of being real with us. So thank you for being here, Dr. Gupta.
Oh, it's my pleasure. Thank you. This is the first time I heard the news, and it was awesome. That was I thought it was really interesting. I loved hearing about the cost of dental school, the amount that people make. I loved the poop story. That was just awesome. It was. I learned a lot.
Who doesn't love a good poop story?
Who doesn't?
Yeah.
And we can tell that Chad doesn't live in one of the areas with the highest paid dentists because his internet sucks.
It's time to lose the AOL dial-up.
It's time to come off the AOL, Chad.
Yeah. Dude, I am trying to figure out what's going on, and I think it's a StreamYard issue and not an internet issue. That's the only thing I can figure because it's happened twice with StreamYard. It hasn't been happening before, so I apologize.
Do you need to run a cord to your neighbor's house?
We're on the same internet, so don't get started.
Or maybe over to Dallas.
Yeah, that's a possibility. That's a possibility.
That could be it.
Yeah. So, anywho, with that being said, Dr. Gupta, tell us about your journey in dentistry.
Oh, my journey's not like super interesting. I'm a dentist, like a lot of dentists. My wife and I graduated together, did residency together, and I know that the reason that I'm on this interview is to talk a little bit about CBCTs, and so how about I talk about that journey? So
I think that journey is interesting. So
yeah,
let's do it.
so I placed my first implant in like, I don't know, like 2009 or something like that. I attended a Gordon Christensen course about implants. I was super revved up. I bought the motor and everything like that, and placed an implant. It was then I placed another one. It was okay. Probably it took maybe a year or two before I started placing them with a decent amount of confidence, where I was happy with the way the x-ray looked afterwards, happy with the way the tissue looked when it was time to restore. And I would hear about CBCTs, but for me, it just seemed like it was cost prohibitive. It was just like, dude, I'm already like, my wife and I, we graduated with about $500,000 of dental school debt. We started a practice, bought a house. We bought the building that was it was just like, dude, I'm not
That's
gonna,
a lot of debt to start with.
yeah. And I
Practice,
was like,
I don't mean to interrupt you, but a practice, $500,000 in dental school debt, a building, and
dude,
a
it was
house.
stupid. Yes.
Wow.
And we thought we still didn't think we were poor. You know what I'm saying? Like, we were about as poor as dirt because of the amount of debt we had, but because we were part of a high income population, we just pretended that we were fine. And, we would get the cocktail when we would go out to dinner with our friends and stuff without it. Actually, like, that's a whole nother story, but our relationship to money, we kind of woke up, that I'll save that for another time. But I was placing these implants. I was learning about CBCTs. I was learning about surgical guides, and I just was trying to avoid the reality of having a CBCT for as long as possible. And in 2018, I had a pretty bad outcome with dental implants. Everything worked out. I sent a patient to a specialist, ENT, all that kind of stuff. The patient was fine, but it really scared me. Like, I couldn't sleep and everything afterwards. So I knew that it was like, well, screw it. We just need to get a CBCT. So we got one, and I would say not all, but the majority of the implants we place now are guided. And the results are just better. They're more parallel. They're more, they're right at the level of the bone. We're choosing the correct implant. Everything is better. And I'm a really big believer in the CBCT for a different reason. And actually, Chad, I have to thank you for introducing me to this, but about probably 2021, 2022, something like that. Chad introduced me to a company called Dental Ray, which automatically reads all of your CTs. You guys probably know about them. Yes.
Yes.
Oh,
Okay.
yes.
I don't need to explain it. Sorry.
But feel free for anyone that's listening. I mean,
I think that's a
absolutely.
very important topic. So go ahead.
I'll just say it. So, and my apologies to people who already know about this, but prior to Dental Ray, the only time I would send my DICOM file, that's that gigantic file with the 5 billion images, the only time I would send that DICOM file to a radiologist was if I was super suspicious of some random thing. That's really rare. I mean, we're dentists. It's not like I can sense that a person has a pituitary tumor or something like that, So in order to do that, you have to compress the file, save it onto a disk, mail it to a radiologist, and then wait for the report. It's a pain in the butt. Chad introduced me to Dental Ray, and basically they just, I don't know, they send their little gremlins into my server, and it automatic, like there's no, I can't choose. The moment that we take a CBCT, it gets sent to an oral radiologist, and it's inexpensive. And since we did that, we have found 2 brain tumors, and we found about maybe 12 or 13 carotid artery atheroscleroses. And that's like 15 people whose lives would have been
changed forever.
Yeah. And I just think about that. Prior to owning a CBCT, I mean, how many hundreds or thousands of patients could have potentially avoided having a stroke, or something even worse. And it's just kind of like an amazing. It's like amazing that I can actually feel like I'm sort of saving people's lives. Not really. I'm not doing anything to save it, but just knowing that the technology is there to at least facilitate people maybe living longer, or not having a stroke, or this, some type of really chaotic outcome, and that's been a really nice thing.
I have to
So
touch
let's
this.
pause right there for a second.
Yeah.
So I think that you bring up a very valid point. And if we were to break down a CBCT, and let's just say that we take a full field of view CBCT.
Mhm.
So let's say a 15x8. Most people will take a 10x8, but let's say we took a 15x8, right? Let's say we even went larger, and we're taking something like Jeff's taking, that's showing us a very expanded field of view. About 94% of that is stuff that we have no idea how to read. We weren't trained. So out of that 15x8 in the larger views, let's say 6% of that is what we should be able to read, which is the maxilla, the mandible, and the dentition. Yet we're responsible for 100% of that image because it was taken in our office.
Yeah.
Am I cutting out, Jeff, or because you're like laughing?
No, that was loud and clear.
Okay.
Yeah,
No.
we got it. You just interrupted me. That's what he's laughing about.
Yeah,
I
I was
started-
just giggling. I just said I wouldn't step on JB like that on her.
I apologize, but I was
It's
talking
okay.
before you started. Oh,
it was a
trust
good
me.
it was a good question. It was worthwhile.
It was a great point. Yeah.
But I do think it's really important that we take those images and we break them down, and we understand what we are trained to read and what we're not trained to read, and that we need to have those that are trained in other aspects read those images to help us. And there's a story that I'll share later, because I certainly want JB to get to her point. There's a story that I'll share later about just this past week. So I'm glad you brought up Dental Ray, but we have really good quality images from PreXion that need to be interpreted appropriately.
Mm-hmm.
Go ahead, JB. Sorry.
Well, I am really glad he brought it up, because we take images and we screen patients a lot more frequently, actually, than what their primary care, unless they're having an issue. Like, let's just take one of the brain tumors, or let's just take one of the carotid calcifications. That would have never been imaged until symptomatic, right? And we do these pre-screens. Some dentists are taking CBCT as an intake mechanism. It's a new patient screen for all patients that come in, especially when they have an interpretation service backing them up. But others are taking it for just a surgical guide, just to make a random thing that they need to fabricate. Or, I want to look for pain on tooth number 13, and I'm digging around for that particular thing, and then other things pop up. So I think you bring up an incredibly valid point of the role that dentists play. We've been pre-screening for hypertension. We've been pre-screening for all these other systemic diseases for a really long time. And CBCT is starting to play this interesting role of pre-screening for some pretty catastrophic disease processes, just by doing our job every day. And the fact that a lot of patients come to see us more frequently than they see their primary care physician. And medicine has really become a lot more reactionary, and that we only image and try to look for things that are symptomatic. If you're not having issues, we don't pre-screen for a lot of stuff. And I love that you've played such a vital role in some patients' lively well-being. And I think that's a really important part for having that technology. And I think also actually a very scary reason why a lot don't pursue it. It's the cost, which you brought up categorically. Mm-hmm. But the other piece of it is what Chad highlighted. How do we interpret that information? What are we liable for? What are we not? And instead of seeing that as a liability, I think you've seen that as an opportunity. And I absolutely love that.
Yeah. Yeah. I do believe also, whether we see it as a liability, like as a thing to be scared of, I think kind of takes away a little bit from just the human element to this too. I mean, we're like healthcare providers, you know what I'm saying? And like it feels like this good to do a great class 2 composite, or it feels like that good to do a sweet looking endo, but like it feels like super good to inform a patient that they have a suspicious calcification in their
Absolutely.
in their artery, you know, and that whether or not, you know, there's a litigious element to that, I think is kind of irrelevant. You know, it's just like, oh, cool. At least I get to go home thinking I kind of maybe sort of saved somebody's life, and that's nice.
I'm really glad to hear you say that, because I mean, this is something that I always preach, which is I take a full field of view on every new patient. Why? Because with PreXion, I get a single pass large field of view. So it's not stitched. The machine doesn't have to go around and expose them twice. The amount of radiation that they're getting exposed to, compared to going to a slightly smaller field of view, it really is almost irrelevant when you compare it to the other X-ray sources that they're exposed to. I mean, I watch physicians prescribe, you know, hospital CT scans for nothing. And, you know, we're taking one of these every few years. But I will tell you first, what you will find compared to what you will miss, I promise. You know, everyone is so worried about the one case, you know, the albatross that's out there that, oh my God, what if I miss this one thing? Well, what about all the things you're missing by not imaging right away? So I take a full field of view. I want to know about their joints. I want to know about their airway. I want to know about the dentition. I want to know about the bone. I want to know about the nasal airway. I want to look at all of these structures. And the other side of that is that you are not responsible for anything that someone with your training, that is someone in your area with your similar training, would not be expected to see. So just because you took it doesn't mean you're responsible for it because it happened to be in the field of view. If someone else with similar training to you is not used to diagnosing pituitary tumors, it's really rare for a jury to come back and say, oh, you know, how could this dumb dentist miss a pituitary tumor, a pituitary tumor, excuse me. I think people get overly worried, but I think having the ability of a really clear image, single pass, you know, not a lot of extra radiation, the benefits so outweigh the risks. And that's why I was so refreshed to hear your response to all of those concerns, Ankur.
Yeah, thanks. You mentioned the PreXion, and that wasn't my original CBCT. My original CBCT was the cheapest one that was available at the time, and I won't tell you the brand because I don't really want to talk bad about any company. But my original CBCT, it did its job to an extent. And then I went to a CE course, and the instructor showed CBCT images from PreXion, and I was just sitting there in the audience, and I was like, "What? My images don't look like that." I was like, what setting do you have?
I know this pain, by the way. I know this pain.
I was like, dude, mine are all crappy and green. And then if a patient had like a lot of metal in their mouth, there's just like,
forget it, toast.
And I was like, what are we looking at here? It was like we weren't even talking about the same technology at all. And so, and then that was one thing. And then the second thing was, like you were saying, Dr. Horowitz, you take a CBCT on a new patient. Well, you want to examine that in the room. Whereas with the CBCT I had, it was the computer. That
exactly.
It was the one that I could look at. So the only time that I would show patient stuff is if the two of us cuddled up against each other, like in the little cove where that computer was, which was like, I mean, so it was uncomfortable. So we barely ever did it. And so it was just actually pretty recently, just a few months ago, that I transitioned over to PreXion, that I finally said, okay, I want to enjoy these images, and I want to be able to toggle through these images in each operatory. And so it was a few months ago that I decided to make the switch to using PreXion instead of the old one.
I don't know what the question is, but having felt this pain, like, we can have a healthy debate. There is an entry point to technology, and sometimes you're just really eager to want to get into that space. So you buy the thing that you can afford. And I can 100% respect that. And I've also lived that categorically. And then there are times where you're like, I'm just going to buy the best on the market, and it will last me for, like, now that you look back on that, would you do any different? Would you do it the exact same?
Dude,
Would you?
JB, the PreXion is the same price as the CBCT.
Oh, geez, OP. Okay.
I just didn't know that it existed. And so it wasn't one of the CBCTs that was highlighted and showcased by the particular distributor that I inquired with. And so it wasn't like, oh man, I just recently upgraded to a more expensive CBCT. It's this. I would have paid the same amount. I just didn't know that PreXion existed.
Yeah.
You know, I just wish I had attended that CE course earlier in my journey, so I could have seen that and I could have bought the right one, because their images are spectacular. I mean, do all three of you have one?
I don't. I'm still operating in my shitty system and my old ecosystem that I'm operating in.
I'm on my fourth. I am on my fourth.
I have one
now. Not because they had to be replaced, but because of just different locations and switching out what I had in different places. But you know, I want to throw this disclaimer out there, and most of the people who watch us understand this. We don't take sponsors on who say, talk about my product. We live the product first, and we understand the customer service and all those things. And I want to ask you what your experience has been with customer service. And then when at least, you know, two of us can speak to the actual experience of using the technology and dealing with the company and working with these people, then we say, okay, now you can be an educational sponsor. We can work together, because we can talk to this and actually speak highly of it without people thinking that, oh, you're just getting paid to talk about that, because that's not who we are. So anyway, it's so nice to hear when someone has an experience like you that came from another company, and that always comes with some pain points. And I want to ask you about some of the pros and cons, but maybe talk to that a little bit now that I've thrown that disclaimer out there. Talk to what some of the pros and cons of lifting a CBCT machine out of your office and putting a new one in has meant to you, and what it did to your practice, and some of the good things that have happened as a result. Yeah.
So I don't want to only talk about pros, because I want to be as honest and upfront as possible about everything, but it's almost all pros. It's like 98% pros. So let me just walk you through it. I saw a CBCT in action by PreXion. I said, those are sweet images. But that wasn't enough to move the needle. I was like, okay, those are cool images, but I don't want to take on the trouble of transitioning yet. Then I attended a different CE course, and in this CE course, the dentist who is teaching is much like you, Dr. Horowitz. The CBCT is part of the initial patient screening. And I was curious about that. I was like, where do you look at it? And the dentist said, no. I can look at the software and toggle through the different views and toggle through the CPR view where you can see the thickness of the bone in the op, in any operatory with any random computer. And I was like, dude, I didn't even know that was possible. That was the inflection point or whatever. I don't know. That was the thing that made me say, okay, no, I need to utilize my CBCT to its maximum, and I can't do that with my current one. And so I said, okay, I want to find out, what is it going to take for me to transition away from my current CBCT and put in a PreXion. All right. I talked to the salesperson, and this is what happened. Number one is they were able to list my current CBCT in whatever CBCT marketplace there is, and they were able to get a buyback offer. Okay. So the only thing I had to do was like take a photo of how many, like some random serial numbers or something like that. Okay. That was number one. After that, they said, okay, are you ready to pay the difference? And I was. And so upon confirming that I could pay the difference, PreXion took care of everything. They scheduled with my office manager what would be an appropriate day to lift the old, install the new, and they worked with my office manager to find out what's an appropriate day to have a live human, real person trainer come into the office and help onboard the entire team. I did nothing. I mean, I opened my wallet, but other than that, I didn't do any work. My office manager did some work, but it just didn't seem like a lot. She didn't seem burdened by it. And then, within a pretty short amount of time, we had the PreXion CBCT in our office, and it's been awesome. Now, the one con, and that is, if you, and JB, you probably know this, you probably are somewhat used to of your imaging software, your way to toggle between, different views, your way to kind of trace the arch and look at the thickness of the bone. To switch to a different software, I don't really care how much training there is, it still sucks. You know what I'm saying? It's like, you can switch from a BlackBerry to an iPhone. Obviously, iPhone's better, but it's going to take a while. You know what I'm saying? Because your fingers are used to using the BlackBerry. And so I would say even now, and it's been a couple months, I still miss certain elements of the software from the previous one, and I don't think it's because of a superiority. I think it's just because my brain and my fingers and my hand-eye coordination was just used to of using a certain type of software, and I don't get to do that now. And so that's probably a learning curve that's just going to take a little bit longer than I had anticipated.
You switch practice management software anytime soon?
Yeah, that's the worst.
Yeah.
Dude,
You did something. Yeah.
What?
In 2021, and that was some growing pains, man.
Yeah, that sucks a lot worse than switching.
Yes,
CBCT software.
So true. You're right.
But that's a very valid point on any technology, and I'm glad you brought it up, because that's something that there's a great book out there that I encourage everybody to read called Who Moved My Cheese? Mm-hmm. And all you're doing is you're moving cheese, and everybody's gonna be pissed off about something, but you know what? In the end, it's all gonna work out. And you'll realize if the team understands your why as to why you switched over to the new software, the new technology that comes with new software, or whatever you did, if they understand your why, it's all going to work out.
Yeah, you're right. Then they can tell already. They love it when I drag the window onto the TV screen that's in front of the patient, and we're all staring at the CBCT together, and that's like incredible. That's incredible. It's actually interesting, Jeff. You mentioned the new patient screening. I don't do that yet. I'm curious to know exactly how your workflow goes, because I don't do it for new patient screening, but we had a mysterious pain in tooth number 3, and the patient had a palatal root fracture. Dude, I would have never seen that. I wouldn't have seen it. And it was so awesome to see it together. Like me, my assistant, and the patient were like scrolling along, doing all. And all of a sudden, we just see that black line, and we're like, "Oh my gosh!"
How powerful is co-discovery? Like,
Oh,
right?
great.
I think that's such a great point.
Yeah. So that part,
and
I love it.
I want to speak a little bit to those individuals that are listening to that maybe bought into the same line that I bought into, and how we're going to dispel that. When I first came into CBCT technology, which was around 2013, I bought into the idea that all ecosystems needed to cohesively talk to one another. So if I was investing in a scanner, a CBCT, this, that, and the other, how important is it that they all communicate well? And I could appreciate that at the time, that made a lot of sense. Since living in that ecosystem for the last 12 years, like, I hate it so much, I want to scream. So I'd like to speak a little bit to how well other CBCTs play with each other. Like, for instance, if you're trying to do a surgical guide, you obviously need the CBCT and an intraoral scan. So intraoral scans coming in, you're building the plan, restoratively driven, trying to put all those pieces together. Different CBCTs do that better than others. So how is that piece of the journey going? And then, make me feel like crap a little bit more.
Wait a second. Are you still using closed systems that require?
Yeah.
Yeah. Dude, okay.
Yeah, because I've invested in the CBCT that it was the closed system and it's still working.
No, I know. It's
and
working.
So you're like, and everything is still working. It just pisses me off every day. So like, I'm not working, but everybody else is still, like, all the things nothing has broken. And until it breaks, and you're like, I mean, I've got 400.
My 1969 El Camino is still working.
Yeah, I know.
But it ain't what I drive every day.
I know. No, I know. But I'm just saying, like, you're looking at it every day going, I got $400,000 invested in this whole closed system BS, frankly.
So how are you going to? Yeah, you're right.
It's not disposable. It's not like a Chinese scanner and a Chinese CBCT that I paid $20 on Temu and it's like this big. Like, I can't just throw it away.
Well, remember though, it's not, if you open your system specifically with just practice management. So let's say you get Open Dental or something like that, or what's another?
I have Open Dental.
Oh, you have Open Dental. Okay. So Open Dental at least allows you to stitch in all of your different software. So let's say you have your X-ray imaging, your intraoral camera imaging, your CBCT. At least that can be stitched in, and those can be all independent. So okay, you have the Open Dental part. So that is the part that's why I was shocked, because
no, that piece I have solved. It's the other technology piece.
Yeah. So that is because I have always had separate entities providing the separate technology for the office. I've never really had, I don't actually even know what it's like to have a bunch of perfectly aligned systems working together. So for example, if I want to make a
probably about as good as what we have, Ankur. Nowadays.
No, it is. There's nothing like
probably about as good as what we have nowadays.
Okay. Yeah. Okay. Yeah. So I if we make a surgical guide, my assistant is sending the STL files from the scan and sending the compressed CBCT whatever to the lab, and that does take an extra second. But we've never known anything else, so we've never been frustrated by that because we don't know of a more efficient way to do that. So I guess I never.
Yeah. Well, the biggest benefit, I guess, of closed system is that you can control and do all of that in-house. Yeah. So that is the benefit.
And I don't have a printer, by the way. I just want to make sure. And if I had a printer, I could see there being I'd see it being really cool to have the printer, the scanner, the CBCT, all
communicating,
all aligned with each other from the same kind of software developer. I can see that being pretty cool. I've just never known that life, so.
But really,
I
that's
think
kind of what an exocad does or something similar is to take those generic files and bring them in and merge them, and that's what your lab is doing. And honestly, I don't think, I mean, and I'm probably, out of the four of us on here, the lowest on the totem pole as far as my digital acumen. I mean, I've been doing CEREC for a long time, but other than that, understanding all these digital workflows is not an easy
He does
thing.
gold foil.
Yeah, it's not as easy as gold foil. That's right. Thank you. Which was actually still on the Northeast Regional Board when I took it. So,
hey,
yeah.
Technology, even with the ecosystem that JB has from 2012 or whenever it was, technology's always been disjointed. I mean, there's always been a disconnect. Even within the ecosystem, you have to expand outside of the ecosystem back then to do other things, and then there were certain things that you were banned from doing. But nowadays I laugh because what I said to Ankur a few minutes ago is so true, that he says, well, I've never been in a system like that. And what we don't realize is right now we still kind of are, but technology is still disjointed to us an extent. But technology is really beautifully disjointed now, in that everything will communicate to one another, maybe with just an extra step. There's a lot of bridging.
We're the conduit.
Yeah, there's exocad, there's portals within the printer systems. I think that the whole thing that's come out of this, based upon what you said, Ankur, is why the hell don't you have a printer?
I don't know.
Yeah,
this is next, because this is not cheaper than a CBCT.
Listen, worse than the printer. Do you know that my wife and I just started using heated composite this year, 2025?
Oh, good Lord.
Dude,
I don't use heated composite.
I don't
Stop your judgment.
Well, in all fairness, I do about 4 composites a month. So.
Well, I mean, we don't know why we didn't use it. And then all of a sudden we use it and we're like, oh, damn, this is like way better.
It's like butter.
It was worth the $80 or whatever,
it's stupid.
smaller. So sometimes it's not a cheap thing. It's just we get excited about different things at different times. And so I need to just
pain points.
By the way, if anyone's thinking about purchasing anything, that 1969 El Camino, I still have a building that's not finished. So if anyone wants that 1969 El Camino.
Are you fundraising right now?
I am fundraising. Okay. Yes.
I have really one important question I want to ask before we wrap it up, because I get asked this. Tanya Sue's going to send me a candle warmer for my composite. So it can be cheaper. I wanted to touch on, because I get asked this a lot, when you're putting all of these different pieces of technology together. Let's do a surgical guide. Let's break down surgical guide workflow. Patient comes in, you're going to place an implant, pick a tooth. Mm-hmm. What does that look like for you in your office? What are you doing as a part of that process? What are you delegating to your lab? What are you delegating to your team? And how have you sort of put all those pieces together? Because I think a lot of doctors, number one, really want to understand workflow. They really want to understand how to leverage team members, third-party vendors, et cetera, and how much should they take on themselves, designing, planning, et cetera. So they like to hear how you do it.
Yeah, sure. Okay. So I do want to make something clear from the start. I have a high degree of trust.
Yeah. You said I said don't have a printer.
Yeah, I have a printer. I have a high degree of trust in my lab techs. So I just want to put that out there. So number one is I almost never do the scan. My assistants are the ones doing the scan. I almost never take the CBCT. It's my assistants who are taking the CBCT. I never am the one who's sending it. Actually, to be honest, I asked my assistants to create a little cheat sheet on how to send stuff to the lab, just so if I ever have to do it, I wouldn't be clueless. Okay, so those two things I don't do. The the decision to place an implant, that I'm part of that decision, but the all of the groundwork in fabricating a surgical guide, I'm very, very much not a part of. Now, the lab that I use, they will ask me, they'll say, Gupta, do you want to have a live meeting where we can go on Zoom and we can look at the surgical plan together? Now, I think that that's actually a very smart idea, especially for a case where the ridge is narrow, or I'm nervous about something or another. Then it's kind of nice to discuss. But when I have just this, 10 millimeter buccal lingual width on 30, it's like a monkey could place the implant. I don't want to waste my time doing a meeting. And so I'll say, just send me like a video, and then I'll like put it on 2x speed, watch the video, watch the little implant, and then I'd say, yes, I approve. And that's just because I feel like this is a lab tech. They make surgical guides all day. They make a lot more surgical guides than I do because I don't have a printer. So then I get the surgical guide. So the amount of work that I do in that process is very, very, very low, almost to the point where, especially for an implant that's a little bit more of a slam dunk, I don't do anything. After the surgical guide is fabricated, I've asked my lab tech to email my assistant team so that they can check and make sure that we have the right implant in inventory. And if we don't, they order it. So have you guys ever heard of a book called Buy Back Your Time? It's by Dan Martell. Mm-hmm. Have you ever heard of this book? Buy Back Your Time.
I do not know this book, and I love self-help books, so go.
Dan Martell, he writes a book. I'm going to type it, Martell, Buy Back Your Time. And like, I just kind of feel like there are, let's say, this many things in my life that I really, 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 really value. And I want to maximize those things. And sometimes if we're devoting a bunch of our time to stuff like, calibrating the scanners or the CT or something like that truly somebody else can do, we are taking away our time from that other stuff. So, nice. Cool logo thing. Nice work.
Yeah, we're pretty legit for being broke.
Well, I mean, you were able to afford that logo, Buy Back Your Time thing, which is
bought that 3 years ago.
We'll probably get shut down for copyright issues now, but it's fine. Whatever.
Yeah.
All right. But yeah.
No, I love that you, I get asked that question a lot. I think Jeff can't really understand this because he's of a different generation. I think we can just all put that out there. But what I see more from younger doctors that are coming out of school, they really value that, trying to find that balance between being a doctor, taking care of their patients, and doing what's best. And they really want to do high quality dentistry, but it cannot be on their backs. Like, Jeff, I'm sure you can relate to this. Like, it can't be them at the lab pressing gold at night. It can't be them at the lab waxing teeth and dentures. It can't be them at night at the office doing surgical guides. No. It's doing what you do well that you get compensated well for, and then leveraging people who also do their craft very well at a price that you can afford, and then, continuing to be incredibly proficient and profitable chairside. And I don't think that can be stated enough. As Paul Goodman has said, dentists are a special kind of cheap, and sometimes we're so cheap to our own demise because we make us work so much harder for $1 than what really should be happening. So I love that you have a partner that you trust. I love that you're empowering your team to support you in that journey, and that you're just profitable and efficient doing the thing that you were trained and most effective at doing. And I think that's a message that we really could probably end the show on, but I think we could really tout for a lot of things. We don't have to do it all. We don't have to own the whole process. We just have to find the right partners to go on that journey. I love that you're doing that.
Yeah,
great final message.
All right. Well, thank you. Thank you so much for having me on the show. This has been a lot of fun for me. And I really love the chemistry that the three of you have, and this has been great. So I appreciate it.
We secretly hate each other.
I was just getting ready to say we're divorcing next week,
Yeah.
but
I can tell.
was happy to have you on our final show. Love that you closed it out for us.
Yeah. Thanks. Appreciate
Actually,
it.
we're just firing Chad.
Do you know what I do want him to do though? Because I do want you to do this, Ankur, if you don't mind. Because one of the things, and I've been working with PreXion for a long time now, one of the things that I love the most about them has been their customer service. Will you just really quickly talk about the level of customer service that you've received? Because, and I like, we've not talked before. I am very confident in asking you this question.
Yeah. Actually, I appreciate you asking. So remember, buy back your time. I was having some software snafus. I couldn't figure out something like how to rotate something or whatever. And so I just asked one of my assistants. I was like, can you, like, when you get a second, can you call them? And she really understood exactly what my limitation was. And well, later, after I was done with, seeing a patient or something like that, she was like, here, let me show you how to do this. And I couldn't believe she got an answer as quickly as she did. And so I was like, when did you call him? And she was like, well, I called him after you talked to me. And she's like, but somebody answered, like somebody was there right away. And both of us were like, huh, like really? Like that happens? Because with our previous service, that never happened. We never received help in real time. And we just assumed that was normal. Now that I've had a chance to talk to a lot of people who are PreXion owners, that's always the case with PreXion. Always the case that you have a problem, you're not sure how to do something, you call. And I noticed they have a huge YouTube library. Like they probably half the answers are probably on the YouTube library, but the person's never a jerk about it. They're never like, dude, have you looked at the YouTube library? They just walk us through things, knowing that we could have saved some time and looking. We
say that too, like at our lectures, like if people ask us a dumb question, we're just like, hey, dude, have you looked at our YouTube?
Yeah. I'm sure people never ask dumb questions.
No. Nope.
So, but I would say that just not even talking about CBCTs, I'm talking about the entire dental industry in general. I think PreXion is probably the most impressive customer service that
I agree.
I really wanted that to be said because that was my experience moving over from, I won't mention the company that I started with, but that was my experience, was just a whole different level of customer service, which is why I'm now on my fourth machine with them and will continue. But so nice for you to be here, Chad.
Before long, you'll have enough that you could actually stitch an entire body together.
Yeah,
we could stack them up. Is that possible? No.
What's this?
If you have 4 CBCTs, could we eventually stack them up and just image an entire body?
Depends on how tall the person is.
Yeah.
Oh, obviously. That is the only limiting factor is how tall they are. We did
image my mother's wrist when she fell down at my house.
Did you do that?
We did. We brought her up and imaged her wrist and diagnosed the break and had to take her to the hospital anyway. And they're like, we're not using your x-ray.
So on that note,
Tanya Sue, her height, we could do it.
Yeah, you gotta be less than 100 centimeters. Tanya, you're good.
She qualifies.
First of all, I just want to thank Ankur for being here, and I also want to thank PreXion for sponsoring tonight's show. They've just been such a great partner, and as you've heard, they're a partner because we believe in them, we use them, and we know that they've got great customer service. But one of the things that we didn't really get to is what makes them stand out from the rest of the crowd. And when we talk about CBCTs, I think there's 4 things that we need to look at. We need to look at focal spot, voxel size, data reconstruction, and then really the amount of images or the flexibility in the images. And PreXion really excels in all of those. They've got one of, if not the smallest focal spot, one of, if not the smallest voxel size. They've got a great data reconstruction, and they've got a lot of flexibility when it comes to the size of images that are available. And beyond that, when you talk to a bunch of oral and maxillofacial radiologists and you ask them, who has the best images, PreXion's always in the mix on that conversation. So I just want to, thank PreXion again. Thank Ankur for being here. If you are looking for a great lecture, look up Dr. Ankur Gupta. He has wonderful presentations coming up. He's all over the place. Go to Catapult Speakers Bureau to see where his next stop is. And until next week, we will see you all later. So
I think we have to have him back for the money talk.
Thanks,
the money
Ankur.
talk
Yeah.
has to go
Oh,
down.
I'd be happy to. I'd be happy to.
Money talk has to happen.
It's a pretty interesting story, so I'd be happy.
Yeah, I think
Yeah,
that's great.
I agree with you. I'd love to hear that.
Jeff's broke, so this is timely.
yeah.
Oh God, yeah. 69.
And on that note, we're just going to go ahead and leave.
All right. Take care, everyone.
Good
Good night,
you.
everybody.
Good night.
Good night.